We think of grandma baking cookies, but think about it now, generationally, these grandmas wore mini skirts and listened to rock and roll and, did recreational drugs. So that stereotype of grandma sitting in a rocking chair doing all those things prevents us from seeing them in their whole totality of how they've lived their lives and what social influences and conditions they're under. So sometimes it just stops people from asking, could this behavior be substance use related? It's not even on the table for many people. I think that's one of the big things. The other is stereotypes of what aging is like, where cognitive decline is expected. And so sometimes people will have that stereotype and not think, could this be due to substance misuse? And so they won't investigate that alley.
This is Countermeasures, brought to you by Emergent, maker of Narcan nasal spray. Join us as we explore the shifting, complex world of the opioid crisis. Today, opioid overdose is a leading cause of accidental death, with so many families, loved ones, and friends behind these lives lost. This season, we'll continue to explore some of the communities hit the hardest by the crisis, from prisons and construction sites to schools and elderly care. We will hear from changemakers offering a new way forward. When many of us think of the opioid crisis, we might not think of older adults. Stereotypes of what it means to age can prevent signs and symptoms of opioid misuse and dependency from being caught by medical professionals, friends and family, and caregivers. However, older adults are a population that is deeply impacted by the opioid crisis and has historically been underaddressed by education, harm reduction, and treatment options. Marianne Mason is a sociologist and an associate professor of emergency medicine at Northwestern University. She's been working in the area of substance and opioid misuse for 10 years, with a focus on older adults.
There has been an increase in opioid overdose deaths in older adults. Older adults are just like younger adults, but their rates are a little lower, but they have followed the curve of everybody else. So since 1999, which is the reference point most of us use, older adult overdose deaths have increased enormously, over 1,000%. There are certain periods during that 1999 to 2024 where the increase has been steeper. And about 2014, 2013 is when the increase started going steeply up. And there have been permutations in the rates, but pretty much upwardly ever since. The major reasons for the increase are the same reasons really behind the overdose increase in general. It began with the overprescription of opioids by physicians, and then it morphed into illicit opioids like heroin. And then when the crackdown came in that and it was harder to get heroin, fentanyl made its way into the drug supply and increased things. And now more recently, we have polysubstance driving the increases. So people who are using opioids and stimulants and opioids and alcohol, those are the substances behind the increase. I just want to point out something really interesting about the older adults. I've been looking closely at the most recent data, and overall in the United States, it looks like opioid drug overdoses are going down slightly from 2022 to 3 and into 24, but that's not the case for older adults. They're continuing to climb for older adults.
Mary Nguyen is a doctor of pharmacy graduate from the University of Waterloo outside of Toronto. She has worked as a pharmacist in a rural community in Ontario, where she saw the effects of the opioid crisis on older adults in the community. Like Marianne, she says that most people don't think about the impact of the opioid crisis on older adults, and that stereotypes of aging can prevent opioid misuse from being identified.
It's surprising how often older adults are affected, even though we don't typically associate them with opioid misuse. People rarely imagine someone like 80-year-old Martha down the street struggling with addiction. But, the opioid crisis really started in the 90s with OxyContin. And now that baby boomer generation who were highly prescribed opioids are older. So we're really seeing that lasting effect. To put it in perspective, 1 in 6 older adults have taken opioids. Opioid use disorder among this group tripled from 2013 to 2018. Older adults are actually the largest users of prescription opioids. So when you think about it that way, it's not as surprising that opioid use disorder is prevalent in the population. Unfortunately, we see a lot of stigma in opioid use or misuse in this population, so it can prevent a lot of diagnosis and treatment.
Mary found that the dangers of developing dependency were not fully understood by patients, especially if they were taking prescription opioids, and that many of these issues were exacerbated by the rural setting.
The lack of resources, especially for comprehensive care and follow-up, really makes it difficult to manage opioid dependency. I've seen many of my patients struggle with dependency, whether or not they realize it, mostly because their long-term use of opioids is often for legitimate reasons, like for chronic pain management. And they're not always the most eager to explore safer options, especially when they think that, opioids work the best for them. People also don't realize how easily dependency can develop. It can take as little as a couple of weeks. And then tolerance is a big issue as well. The longer you're on opioids, the less effective they become, which leads to taking higher doses and a greater risk of dependency. Many assume that because a medication is prescribed, it's safe. Especially if something they've been taking for a long time, they're less likely to stop because they don't think it's an issue. Our healthcare system in Canada is quite strained. Doctors' offices are overloaded. Sometimes they don't have time to give proper education or ongoing check-ins for these patients who are on long-term medications.
In rural settings especially, tools like naloxone can be crucial.
It's really important to reduce that stigma around naloxone. Many people hesitate to carry naloxone or take it when it's offered because they think it implies that they're an addict of some sort. I like to reframe it as a safety tool. It's like having a fire extinguisher in your kitchen just in case of emergencies. It's not that we think you're abusing your medications, but if you were to accidentally take too much or if someone else were to get into your medications, it's there as a safety net. And I think, with the evolution of injectable naloxone to nasal naloxone kits, people are less hesitant to carry it because it's a lot easier to use. Most people don't want to carry around a needle and syringe and have to poke someone in an emergency.
Well, one way older adults are affected by the opioid crisis is misuse of opioids that were prescribed to them. Some older adults may have a long history of using illicit drugs. The rise of fentanyl has put this population at greater risk.
Older adults, there's kind of 2 types of opioid misuse. One is early onset, where people may have a 20, 30, 40, 50-year history of substance misuse, and then late onset that happens in their older years, and that's mostly prescription-oriented. So you kind of have to think about 2 distinct groups of people, older adults who are using. So the younger onset people, there could be a variety of reasons why they've misused and continued to misuse, including untreated pain, mental health issues, sort of cultural norms, generational cultural norms. And then for the older adults who initiate, it's more likely to have to do with prescription use that builds dependency. The disparities are very stark. So among older adults, it's the 55 to 64-year-olds who are disproportionately affected, and then men, and then African American men. And so while there's not a ton of definitive research on this, I think the general thought is that it's a generational impact, meaning that it's a group that's likely had early onset use and maintained their use over decades. And so they're survivors, right? They've been able to survive with substance use for 30, 40, 50 years. But now we're in a situation where the potency of the drug supply combined with their aging has put them at proportionate risk. So the older adult, or the young old, as I like to call this group of African American men, sort of have a generational legacy in that way. In that, if you think back to the 1970s, there was a heroin epidemic. A lot of us don't think that far back, but that was the population ensnared in that epidemic. And I think this population now, they're older adults, they have continued to use and are ensnared in the new epidemic with greater risk.
Jessica Liebster is a case manager at West Neighborhood House, a multi-service organization in Toronto that serves the community to address critical issues through personal and social change. A large portion of their programming is targeted at older adults in the community, some of whom have struggled with chronic opioid misuse. One of their programs includes volunteers going into the homes of seniors in the community who might be isolated.
That program provides volunteer support to connect with participants. So sometimes they will get a weekly call if they would like to just chat and, have a connection on a weekly basis. So through that, then we're able to link up to other support services. So sometimes people don't identify, they don't want to ask for services that they think maybe are for other people, right? Like people are sometimes very proud, or they don't want to access charity because they don't see themselves in that light. But we know that all of these social supports, most people can benefit from, right? So, but some people will then say, but yeah, I am kind of lonely. It would be nice to connect with a volunteer. But the volunteer then can identify all kinds of needs and supports. And when things deteriorate, as they can, in terms of health or mental health or what have you, then the friendly visitor or the friendly connection volunteer can say, hey, this person, is struggling a bit, and get some advice or support on how they can refer them to other services. So that piece, it's, I think, really significant because it catches a lot of folks who wouldn't necessarily see themselves as needing case management, but there is an element of identifying what some of the needs are through that program.
Like both Mary and Marianne, Jessica has seen the intersection of social isolation, poverty, and substance misuse.
Substance use, we're maybe thinking of a younger population, so there's less awareness, and that always, less awareness always leads to less access to service, as well as maybe somebody not identifying their own needs in that regard because they see themselves as different, say, than, other substance users that, maybe are kind of sensationalized in the media or what have you, right? So I think that ensuring that we're kind of shining a light on substance use with older adults is really important. And I also think too, the older adult population within, homeless or underhoused folks is not really acknowledged. We see lots of older adults who are unhoused, maybe living in shelter for a long time, or living, sleeping outside, using substances. And so, that piece I think can also get missed because we're looking at the impact of poverty, like severe, poverty, in addition to aging, in addition to substance use. So there's some very specific needs there that require a bit of a nuanced perspective to respond to.
And then specific to the older adult, there's lots of different things, but key to this group are things like income inequality. So people with lower income tend to have less opportunity for medical insurance to treat pain. And so there's this idea that people self-medicate when they're not able to get medical care. There's also this idea, and it's well documented, structural racism in the United States, where African Americans were actually less likely to be treated for pain with opioids than other populations. And so again, it leads one to think about the development of illicit use. So you think about those sort of legacy factors, the fact that people don't have health care, that they've experienced, lifetimes of racism, that they don't have access to things like stable housing, which could help them manage these conditions, and the fact that employment and things like that is so racialized in the United States. You can kind of see how this happened.
As a pharmacist, Mary saw the impact of the pandemic on older adults, which augments the social isolation that can contribute to substance use disorder.
COVID-19 made things much harder. During the pandemic, I saw a sharp rise in opioid abuse, with more patients starting medication-assisted treatment, increased in relapses, more naloxone requests, and treatments for other substance use disorders like alcohol use. And I really do think it's from that isolation, increasing the stress and anxiety leading to the substance use. With healthcare services limited during lockdowns, it's tough to get the support you need, right? And with the pandemic, it also led to shifts in the opioid prescription regulations in Ontario. Because there weren't as many in-office visits and limiting the transmission risks of COVID, the Ontario government provided looser restrictions on opioid prescription transfers and longer dispensing intervals, but that inadvertently increased the risk of drug diversion. Across Canada, we saw increases in opioid-related hospitalizations and fatal overdoses, especially from fentanyl. But from my experience, the elderly patients were the most impacted by opioid disorder because those were the ones often without a strong social support, and a challenge that was further, exacerbated by the pandemic.
Mary has also seen that the healthcare profession has a ways to go when it comes to this issue, including in long-term care.
A lot of times when patients go to long-term care homes, the healthcare they receive is often, okay, is there another problem we need to address? Let's add on medication. It's very rarely that a doctor goes in and like, hey, let's see what we can take away. And it's a practice that is starting to become more popular, especially as you see so many interactions between the different medications. And, just because someone needed something at one point doesn't mean they need to be on it forever. And as pharmacists, specifically coming more into long-term care homes, we are coming in doing medication reviews to deprescribe, to minimize the risks. A big thing with opioid use, with the cognitive decline, is the fall risk. Older adults, if they have a bad fall, I think 50% of patients who had a hip fracture aren't able to return back to their normal independent living anymore after that. So I think it's a big intervention that pharmacists can play.
Like Mary, Marianne believes that treatment is not curated to this population.
No, I don't think there's the services tailored to older adults out there for people, or at least in the quantity and the places where people need them. First of all, if you are talking about recovery and treatment, there are some things older adults may need that the general population doesn't, just because of how we age. So they might have transportation or mobility barriers, so they may have different needs there. They may have hearing or vision issues that necessitate delivering supports and services. There's been some work done looking at sort of the culture of recovery and how that works, and the idea that sort of group therapy, talking about your things in a group, is not in alignment with what many older adults feel is comfortable for them. So there are adaptations that need to be made that way. But also, medication-assisted recovery, which we know is an effective treatment for opioid use disorder, is less often offered to older adults than younger adults. And so, should that be something people are interested in? They're not being asked.
Marianne also believes that there is more work to be done to tailor current programs to the needs of older adults.
Older adults have, come of age in a time where that wasn't a thing. It wasn't an option for them, or that you had to go to specialized treatment. So many don't know you can get substance use disorder treatment at your primary care physician's office. So there's a couple of things there. One is the education of the older adult community about what's now available, but two, the education of providers to offering things. And then I guess three is, how do we adapt things being offered to the needs of older adults? We have a long way to go. If you think about harm reduction are services that can help people who use drugs be safer and less risky. And there's a whole, menu of effective strategies people can use in harm reduction. Anything from syringe distribution to test strips so you can test your drug supply to drug checking. All of those things are in the harm reduction menu or bucket, but there's evidence showing that older adults are less often touched by harm reduction. And there's, again, a couple of theories about why they're less often reached, but part of it has to do with stigma. And you think about this population generationally, there was this whole, I'm going to use a word we don't use anymore, but this junkie label for people where there's quite a bit of shame and personal failing associated with substance use. So people do not want to identify with that. Sometimes for older adults, they may have gone through a period of abstaining for a number of years and then have recently or more recently gone back to use. And so they really don't want to go out to the mobile van and stand in line for services because they don't want to self-identify as someone who's using again. The other fact is transportation and mobility. People aren't in the places where they used to hang out and use drugs in their older days, so they can't be reached in those places as often. So I think we've got a ton of work to do around strategies to reach this group with this population with those strategies.
Older adults are a large, complex, and diverse group, and opioid dependency looks different among different populations. However, stereotypes about aging and stigma surrounding opioid misuse can prevent older adults from seeking treatment, or for dependency to be caught in the first place. In addition, harm reduction services and supports tailored to older adults are lacking. Increased interest and research into this area will help improve outcomes for everyone. Thank you for listening to this episode of Countermeasures. To learn more about what Emergent is doing to help address public health challenges like the opioid crisis, visit emergentbiosolutions.com. If this episode resonated with you, consider rating and reviewing Countermeasures on your preferred podcast platform.